My name is Dr. Thomas Westwood. I'm a consultant radionuclide radiologist at the Christie. Tom's fine. And I'm going to be talking today on the radiology of lung neuroendocrine tumours. There's a couple of things I wanted to sort of clarify right at the start of the talk. I don't know if it's just sort of stating the obvious, but these things are, first of all, what is a radiologist, and what is a radiographer, because that can sometimes cause confusion with people. So a radiologist is as a doctor that specializes in diagnostic investigations. So they'll have a medical degree and a minimum of 2 years as a non-specialty junior doctor before they then specialize as a specialist radiology trainee. And then often they'll have had further training to report more specialist investigations within the particular subspecialty that they choose. And they might also perform treatments such as interventional radiologists who perform procedures, or nuclear medicine therapies, such as PRRT, which is something we'll be touching on later in the talk. A radiographer is somebody who operates the radiographic equipment to produce the scans and things that the radiologist then interprets. But radiographers may also train up to perform ultrasounds and to report some specific types of diagnostic investigations, and also to deliver radiotherapy. So they have their own specialties in their own rights. But that was to clarify that point, which can cause confusion. The second thing was just the terminology around neuroendocrine tumours can be extremely varied and used quite loosely. And there's all sorts of different names get used by different people. So for the purpose of this talk, all these different names, neuroendocrine cancers, neuroendocrine neoplasms or NENs, neuroendocrine tumours, neuroendocrine carcinomas and carcinoid tumours. The one which we use locally at the Christie and which I will use is neuroendocrine tumours or NETs. I'll do that because that's what I use on a daily basis, and if I try and do anything different, I'll no doubt be inconsistent and confuse people even more. So I'll just stick to the one that we normally use. They all refer to cancers of neuroendocrine origin. So a bit of background about neuroendocrine tumours. Neuroendocrine tumours make up a group of malignant tumours. Even that in itself is an important point because it's not something that's sort of universally recognised. If we go back a few decades, then it wasn't really universally recognized that all neuroendocrine tumours were malignant because some were so slow growing, and that messaging is an important thing to be stressed to all different health professionals, so that they are aware of the importance of managing these tumours correctly. Previously, they were all known as carcinoids, and now that's reserved for the lung neuroendocrine tumours, or a subgroup of the lung neuroendocrine tumours. But what they all share in common is that they arise from a precursor endocrine cell, which is where they get the name neuroendocrine from. And what that means is a sort of parent cell that they all share in common, irrespective of where they are in the body. But despite that, having that shared similarity, they do show a really broad range of behavior, ranging from quite slow growing and what we could call indolent to being quite aggressive. So that range of behaviors and locations in the body makes for quite a challenging sort of group of entities to manage for the doctors. So in order to sort of help with that challenge, we need to break down the broad range of neuroendocrine tumours into smaller subcategories, because then we can group them according to behaviour and assign treatment based on sort of groups of similar behaving tumours. That relies on having a biopsy, so having a sample of the tumour. And the way we break them down using those biopsies is to grade them according to their sort of the aggressiveness of their behavior. So the least aggressive tumours we refer to as the typical carcinoid tumours. They're classed as grade 1, so the grade is really the sort of a way of quantifying the aggressiveness. And the way we decide if things are grade 1 and typical carcinoids is we look at I say that we look at the pathologist who looks at the biopsy will look at how well differentiated the tumor is. And what differentiation is a measure of how closely the tumor resembles a sort of well-functioning soft tissue. So the typicals and atypicals, the grade 1s and 2s, they resemble a sort of normally functioning tissue quite closely, whereas the more aggressive the tumor gets, the more distorted the architecture of the tumor gets, then we start calling those poorly differentiated. Another thing that gets looked at is this thing called the mitotic count, which is a measure of how many cells are dividing at any one time. If you have more cells dividing, that means your tumor is growing more quickly and behaving more aggressively. So these well-differentiated typical and atypical tumors have low mitotic counts. And you can see they're much lower than the higher grade tumors, which have dramatically higher mitotic counts. And actually the behavior of these typical and atypical tumors is sufficiently different to these high grade tumors that it's quite common and a normal practice for a different group of doctors to manage these high grade tumors. Necrosis is when the center of a tumor becomes sort of mushy and almost sort of rotten in the center. That happens because if tumors grow very quickly, they outstrip their own blood supply, and the center doesn't get enough oxygen, and it becomes mushy. So you have that happening in the more aggressive tumors and less so in the less aggressive tumors. So this is the way we characterize things. And that's a really important concept to have an understanding of, because it will affect the treatment and the imaging that's appropriate. This is I just brush over this, but this is to show the mitotic count, and it's literally the pathologist looks down the microscope and counts the number of dividing cells. This one on the right here has 3 dividing cells in this high power field, so is an atypical carcinoid. This one doesn't seem to have any, so this is typical. And the take-home message from this is that biopsy is absolutely critical in deciding on how to treat an individual person's neuroendocrine tumor, which then might make you think, well, if biopsy is that important, is imaging actually that important? Well, it is actually also completely critical, because the two go hand in hand, and it's very difficult to manage somebody effectively when you have one but not the other. So both biopsy and imaging really are the 2 main things that go towards making that decision as to what to do next. When we look at imaging, it's the concept I like to use is this toolbox, the imaging toolbox. And I like the sort of toolbox analogy, because it reflects the fact that we have quite a wide choice of imaging investigations that we can do, but we need to choose the right one at the right time, just as you would if you were fixing a car and choosing your tools from your toolbox. You need to choose the right tool for the right task. Within imaging, we divide our investigations up between radiology and nuclear medicine in general. And they're usually separate departments in the hospital. And the radiology investigations are these, so X-rays, ultrasound, CT, and MR. Those are the main ones, and they in general look at how widely a tumor has spread in the body. Nuclear medicine investigations are different from radiology in that they involve, they might also involve some of the same technology, but they also, in addition to that, involve injecting radioactive substances into the body. And the ones that commonly are used in neuroendocrine tumors are octreotide scans, some people may have come across, but then also PET-CT scans, which are much more ubiquitous nowadays. And there's 2 different types, which we'll go into in a second, but these don't just look at the spread of the tumour, they also look at function of tumours as well. Just quickly look in a bit more detail about the different types of imaging technology, imaging modality that we have. Plain films or X-rays, as they're generally called, have been in use for a really long time. So the first X-rays, of which this is one, which the professor who discovered them took a picture of his own hand, and it became very famous. They've been around since 1895. And like a lot of things that have been around for that long, they've largely been replaced by newer technologies. So certainly for the staging of cancers and for the follow-up of cancers, we generally need something that's more gives more detail and is a bit more accurate than plain films. But that said, they're still very useful in particular circumstances. So for acute illnesses such as chest infections, and particularly for bone imaging, there's still nothing that really replaces the detail you get of bones with plain films. So they're still used, and a lot of people will still experience having these. These are the X-ray machines that we have at the Christie Hospital. Took these images off a sort of a Google Maps thing that we have at the Christie Hospital, because I didn't want to steal anyone else's pictures off the internet, so that's why they've got arrows in the middle. But I'm sure people will be familiar with these. CT, on the other hand, sometimes called CAT scans, is the real workhorse of the modern radiology department. CT still uses X-rays, but this is a picture of one of our X-ray CT machines. Inside this donut, there's an X-ray or multiple X-ray machines that spin around and take lots of images very quickly and use computers to build up these more detailed images, which give you an accurate cross-section through the body than you get with a plain radiograph. They might also, or they usually also, use an injected, what we call a dye or a contrast agent, and that makes the pictures a little bit less grey, gives them a bit more contrast. CT is extremely useful for a really wide range of things. So they help to make diagnosis by finding and characterizing abnormalities. They can establish the spread of tumour, and they can help plan the actual biopsy and surgery. And they also help in assessing post-treatment change, so judging how well treatments have worked. So they really are used in all sorts of different scenarios, and really complement the biopsy, because the biopsy might say exactly what one individual lesion is, but it won't say how far it's spread, or they might also, how do you know where to take the biopsy from if you don't have the CT scan? So the two go hand in hand. This is a example of the way that we look at a CT scan. So this is a scan through a person's chest. So these darker areas of the lungs. So that's actually the right lung, even though it's on the left of the image, and that's the left lung. It's just how we look at them. This is the heart in the middle. Over on this left side here is this little grey nodule, which you can see there's a cross on there. Someone's measured it. That's a lung neuroendocrine tumour. These are the spine and the ribs wrapping around. We scroll through the images and we see a whole three-dimensional picture of the body that way. Moving on from CT, you can see that the MR suite at the Christie has had a more recent makeover than the CT and the plain film suites. Hopefully soon the CT department will look like this as well. This is a much nicer environment to be in. Magnetic resonance imaging, or MR, people might have also experienced. This, rather than using X-rays to make images, it uses strong magnetic fields combined with radio waves to produce images. It's really quite complicated when you're learning about how that works, but it does. And again, like CT, the the technology might be combined with an injected contrast agent or dye to make the images more detailed. The images we get from MR are really very highly detailed, but they're usually of quite limited areas of the body. So whereas in CT, we can scan the whole body in just a matter of seconds, the MR images take a lot longer to generate. The scanners can also be quite noisy and a little bit tight-fitting. So you can see here, compared to the CT scanner, the donut's slightly longer and a little bit narrower, but the modern machines are much better with regards to sort of claustrophobia than the old machines used to be, which were really very tight. With neuroendocrine tumor, the most common use of MR is to look at the liver. So here's a liver MR, and you can see all these black dots are metastases in this patient's liver. The reason why that's better than CT is that CT has a sort of limit to the size of the lesions that we can see, so it won't see things as small as this. We often also use it for the brain and spine as well. And moving on from that, the nuclear medicine test, so PET-CT. PET-CT combines CT with a nuclear medicine imaging technique called PET, which actually stands for something called positron emission tomography, but it's a bit of a mouthful, so we just call it PET. And like I said before, that's where you inject a radioactive dye as well as doing the CT scan. And the scanner, as well as being able to shine images, shine X-rays into the body, it's able to detect X-rays coming out of the body and build up an image of where the radioactive tracer has gone. So on this image here, you can see alongside the image, the information that we had on the CT scan on the previous examples, and we've also got the color added, and the color is where the radioactive dye has gone to. We use different tracers depending on the scenario. So you might have different types of PET scan. The uses are very broad ranging, again, similar to CT. And we'll touch on that again in a second. The two main types of PET-CT that you'll come across in neuroendocrine tumors, don't worry about these diagrams, they're just there for a bit of color really, but the one of them is FDG PET-CT and the other is gallium DOTA PET-CT. FDG PET-CT looks at sugar in the body. So you inject a radioactive type of sugar, and tumor cells in general metabolize or consume a lot of sugar. So the sugar gets trapped inside the tumor cells, and because it's trapped in individual locations, the camera can then detect where it's gone to and show you where the tumor cells are, which is a really helpful for lots of different types of tumor. But the slight difficulty with that technology is that all the other parts of the body are using glucose to some degree as well, so that can cause problems. Gallium PET-CT, instead of looking at glucose metabolism, looks at what we call a target. So it looks at a structure on the surface of the tumor cells. In the case of neuroendocrine tumors, it's looking for something called a somatostatin receptor, and that's something that is overexpressed. This is somatostatin receptor. There's more of them on neuroendocrine tumors than most other parts of the body. And this is looking at a diagram of what the tracer actually looks like on a sort of molecular level. You have a particular part of the tracer, which is the DOTA part of the name, that attaches onto the receptor, and that's linked to a radioactive substance, which is the gallium. This is just to quickly show that there's more of these receptors on tumor cells than on normal cells, which is why you get accumulation of the radioactive substance and why you get the signal that you detect with the scanner. These two techniques are of different use in the different types of neuroendocrine tumor. So the more aggressive tumors consume much more glucose than the well-differentiated carcinoid or neuroendocrine tumors, which actually are quite unusual amongst all the different types of tumor that we look at, in that they don't use much glucose. They don't need much glucose to survive, and that's one of the reasons that they can be very slow growing. But the more aggressive tumors do use a lot of glucose, which means that FDG PET is useful for the more aggressive tumors, but tends to not be as useful for the less aggressive tumors. Likewise, the less aggressive tumors express much more of these somatostatin receptors than the more aggressive tumors, which become dedifferentiated and no longer express the somatostatin receptors. So that means that the gallium PET is much more useful in the well-differentiated tumors than the poorly differentiated tumors, and for the poorly differentiated tumors, we use FDG PET. So which PET should each patient have? Well, as I've said, in general, we use FDG for the higher grade tumors and gallium PET CT for the lower grade tumors. That isn't to say that if you have a low grade tumor, you would not receive a FDG PET, however, because FDG PET is used very widely in the diagnosis of lung cancers. So if you have a scan and it shows something that's suspicious for a lung cancer, and we don't yet know that it's a neuroendocrine tumor, the next go-to investigation will be an FDG PET CT, and then the biopsy would happen. And it's only after the biopsy that you then know that the gallium PET might be a useful investigation. So here's some examples of, this is an FDG PET CT. You can see the lung nodule here. This is the little bit of uptake, the red color that belongs to that nodule. It's what we call slightly misregistered, so it's not quite coinciding with the nodule perfectly. That's just because of the technology sometimes doesn't get it quite right. And you can see that it's a little bit red, but it's not particularly bright. And that's because there's not a huge amount of the somatostatin receptors in that nodule. Whereas this is a gallium PET CT, hang on, it will be in a second, of the same lesion, and you can see how bright and intense that uptake is on the gallium PET CT. So that's a good example of the different behavior of the two techniques. Gallium PET CT then is highly accurate, and because these tumors shine so brightly, it can help us pick up absolutely tiny lesions, much smaller than you might detect with just a conventional CT scan. And it's also a very good way of assessing response to treatment, because we can see whether the activity has kind of switched off. Sometimes tumors might not decrease much in size, but they'll have a decrease in uptake, and that's a good sign that they're responding. They might also allow us to decide on therapy options, and that's where PRRT and molecular radiotherapy comes in. So this is something that I specialize in, and that I was specifically asked to talk about. I can see I may be getting a bit short on time, but I want to cover this because I think it's important. The concept of molecular radiotherapy is that if we can see the tumor on a scan, we can also treat it. And what that means is, it goes back to this diagram that we had before. So if we can have this technology that allows us to see these somatostatin receptors that the tumors have on their surface, we can sort of hijack this same technology to deliver radiotherapy to the tumors. And the way that works is, instead of having the gallium attached to the molecule, which is sort of mildly radioactive, we can attach a different substance, a different radioactive substance, which gives out higher energy radiation. And the idea of doing that is that, this is happening many times over for each tumor. Enough radiotherapy will be delivered to the tumors to either to stop them growing or to shrink them when this happens on a large scale. The advantages of delivering radiotherapy that way, compared to just shining it into the body with a camera type machine, which is how conventional radiotherapy works, is it enables you to give a larger dose to a much smaller area. And it also allows you to treat multiple lesions that have spread throughout the body, when you wouldn't really be able to do that with conventional radiotherapy because of side effects and toxicity. An example this is actually in a small bowel neuroendocrine tumor, because that's where we use PRT the most. This is a PET-CT. It's slightly different way of looking at PET-CT images, but this is a PET-CT image that's used gallium PET to show this tumor, which is in the pelvis and is spreading up through the patient's abdomen. These are the post-treatment images of the same patient, where the lutetium, which is the PRT agent, has been injected, and we do scans afterwards to see where it's gone, and you can see it's gone to exactly the same place. And we kind of know it's going to do that before we do this, but we always do the post-treatment imaging to check. And that's, that exemplifies the principle of, if we can see it, we can treat it. There's good evidence for doing that in the gastroenteropancreatic, so the abdominal neuroendocrine tumors. That comes from the Natter-1 trial, which many of you may be aware of, which showed that lutetium offered improved progression-free survival over standard therapy. So the progression-free survival in the group of patients who received PRT was 14 months compared with 8 months in the patients on conventional therapy. There isn't the same level of evidence for using PRT in lung neuroendocrine tumors, unfortunately, at the moment. The only studies that we have in lung neuroendocrine tumors were much smaller studies that generally looked at patients that hadn't really been planned as part of a study. We're just looking back at what had happened to patients who had the treatment in the past, and that meant they're poorly powered, which is where the study doesn't really have as much weight to justify using a treatment. And the studies that have been performed have been a little bit less encouraging for the lung tumors than for the other abdominal tumors. You can see that the progression-free survival was lower for the lung groups, but as I've said, this isn't reliable data. This is from very small numbers, and even the abdominal tumor figures weren't as good in these studies as the Natter-1 data, which suggests again that it's not reliable. They did show that the progression-free survival was better in the typical carcinoids and the atypical carcinoids after PRT, which is kind of to be expected. But that strength of evidence really isn't quite there yet. And on top of that, there have been other studies in this particular group of tumors, not necessarily looking at PRT, but looking at other therapies that haven't succeeded in recruiting enough patients, and that's largely because we're looking at quite a small subset of a rare tumor group. But metastatic lung nets aren't that much less common than the gastrointestinal sort of counterparts, and we have succeeded in that group. There's been a lot of effort to reduce variability in practice and to coordinate things. Professor Mansour's LEAP study is a good example of that, and you can hear more about that from his recorded talks. And there's sort of the lay of the land with regards research should improve as we improve the coordinated nature of care for patients with neuroendocrine tumor. There's also more of a drive at the moment in cases where it's very difficult to generate high power evidence, to get more organized with collecting real world data, and we do that with what's called cancer registries, whereas if each time a patient has a particular treatment, all the information about that treatment is entered as it is generated into a registry, and once enough information is collected to look back at it and to see how much success there's been, then you can generate the evidence you need in a different way. So that's something that's quite promising for neuroendocrine tumor and PRT. There's also strength in numbers. So what I mean by this is that whilst individual rare tumours are rare, rare tumours as a whole aren't actually rare. So if you group together all the different types of rare cancer, they actually account for almost a quarter of all cancers. So there's lots of good initiatives that are trying to join groups of patients with rare cancers together and professionals who study rare cancers together to lobby and to campaign for better funding and more interest in tumours that would traditionally be considered rare. So these are some of those groups that I think are well worth having a look at and encouraging. So as a summary, I hope I've not waffled on too long and bored people in any way, but there are many different options for imaging lung neuroendocrine tumours. Biopsy is absolutely critical, but the biopsy and the imaging really go hand in hand together and underpin how we choose treatments and make management decisions for people with neuroendocrine tumours. Gallium PET-CT in particular can be a very powerful imaging tool for neuroendocrine tumours, and the availability, whilst at the moment is patchy through the country, will continue to improve, and we're all in my field of medicine, we're all working to try and improve that. Molecular radiotherapy, PRRT, may also have a role, but at present we haven't quite got the amount of evidence, the strength of evidence that we need for that to be rolled out nationally. But different medical professionals agreeing to follow set pathways with regards to treating people with neuroendocrine tumours will help generate that real world evidence that then allows the idea of more trials in this group to gather traction and to be more appealing.